Now, the fulcrum stretch exercises are a similar position as the warm-up protocol in video number 1 and preparatory to doing these exercises here. So we have the lumbar spine in such a lumbar fulcrum in such a way that the crest of the ilia, the top of the hip bone here, not the hip bone, but the ilia actually, the hip bone is here, this is the ilia. But we commonly in our culture call this the hip. And so then we're going to take the crest of the ilia and we're going to drop the fingers down to the floor, and that's where the bottom of the fulcrum goes. If there's any question, do not move the fulcrum downward, move it upward slightly, and I mean very slightly, and you'll find by doing that that your pelvis tends to want to droop over the fulcrum a lot more ideally. You cannot harm yourself by coming too high. It can be a problem done too much and for too prolonged a period of time with the fulcrum too low. You'll alter the ideal pivot point in the lumbar spine too low, and that'll create a problem. And so in the cervical spine, the fulcrum goes tight against the shoulder, the head is rolling down the hill, you're controlling the pivot point on the neck region. So in this exercise protocol, you let the hips droop down to the degree that you're comfortable with and you can tolerate. If you can't, just simply flex the abdominal muscles and decompress the lumbar spine a little bit so it's not too difficult for you. So first of all, we're going to be bending the head from side to side. And again, we're sliding the head across the block, not rolling the head across the block. So in the first one, it's kind of real important to keep the chin in midline. Sometimes in the early stages, we have the patient do the prayer position in which the chin is constantly in touch with the fingertips, looking upward like that, and we tell them to slide the head from side to side on the block and try to keep the chin in midline when you do that. A lot of people have so much pathomechanics in the spine that it's difficult for them to do this rehab protocol, and that's why it's so important. And because the pivot point is controlled, the vectors always are forced to go into midline no matter which direction of displacement is taking place in the global cervical spine. And so lateral flexion first. Then the next one would be rotation. And again, rotation is a turning motion, and again with an upward gaze and an upward gaze, and we're going to go in and turn and stretch, turn and stretch, turn and stretch, turn and stretch, turn and stretch. Then the third exercise would be tucking the chin, again tongue in the frenulum, chin in, way up, chin in, way up. I actually tell the patients to try to take the back of their head and keep trying to push the block back down to their shoulders. Chin tuck, chin extension. By this time, enough time on the lumbar fulcrum will tend to stretch the lumbar muscles enough so that they'll be a little bit more comfortable on the lumbar part of the lumbar fulcrum. So now we're going to engage what we call the fulcrum stretch exercise. And that motion will be picking up one leg at a time and bringing it all the way up into the chest region. But there are very, very definitive steps in this program and this protocol that have to be done properly. So the very first thing is simply bring the foot off the floor. That's increasing the tension quite a bit and quite a bit of work and redeveloping the tonicity and function and strength of the psoas muscles. Now, we're going to bring first of all, if you're warmed up thoroughly enough by now, the pelvis will be pretty close to the floor. Ideal scene, bring the foot off the floor without raising the hips off the floor. Then raise the hips off the floor, create a pelvic tilt situation, and grab the knee and bring it and tightening it up and stretching it up to the chest. Do not help it up. Do not help it down. Let the hip go down in such a way that the hips or the buttocks hits the floor or comes close to the floor first, and then put the foot down. The alternate side would be the same thing. Let the pelvis droop down. Do not lift the pelvis first. Bring the foot up first. Then bring the pelvis into that flex posture, and then stretch it up to the chest real strongly. Let it go. Use muscle power to get all the way down, but don't put the foot on the floor until the very last minute. Foot goes down on the floor. So this is how we commonly teach it in the office. Foot, butt, chest, butt, foot. Foot, butt, chest, butt, foot. Foot, butt, chest, butt, foot. And once the patient is acclimated, then they can start to get into cervical flexion as in concert with the protocol, which would be more rehabilitative on that. And so, again, we probably do about 10 or 15 of them on each leg if we could, and some of them without the head being tucked and some of them with being tucked, but always first without the head being tucked. Then the last protocol for the fulcrum stretch would be to bring the foot up, leave the butt down, and go down and put the knee on the floor. Raise the knee back up, put the foot back on the floor. Raise the foot up, let the knee go all the way out, bring the foot all the way in, down on the floor. In the more advanced stage, we could bring it up and bring the pelvis up and get a different plane of motion with the engaging more of the upper lumbar spine into the thoracic and thoracolumbar region. But to begin with, just get it up, get it out, up, down. Foot, knee out, foot down, knee up, down, and as you can see, one might be less mobile than the other, and obviously stretch the one that doesn't go as far a little bit more assertively to get the proper ideal effect and equilateral function in the system.